Welcome everybody and good morning, at least if you're in Europe. My name is Gusta Wachter and I'm the Executive Assistant of IPS and also a PhD student at NIDI. And together with my colleague Nico van Nimwegen, I will be hosting today's webinar, or the first webinar of the day, I should say, which is about health, well-being and morbidity. And we are very happy to see so many of you again. More than 100 people signed up for this webinar, so that is really great. And of course, a special welcome also to our presenters. I should say that this webinar was originally organized by Kieran Barclay, but unfortunately he could not be here with us. So Sven Dreval stepped in as a chair. So thank you, Sven, for doing that on short notice. I would like to mention that this webinar is being recorded, so if you want to take a look at it again afterwards, or if you want to share it with your colleagues, that's possible. We will upload it to our website. Now, before I hand over to our chair, I would like to give some tips on how to make sure that this webinar runs smoothly. And that is that if you have a question to one of the presenters, please post it in the Q&A box, which you can find at the bottom of your screen. And if you have a question to a particular presenter, please also state that in the question so we know whom to ask this question to. And then after all the presentations are done, the chair will open the discussion and he will select some of the questions from the Q&A box. And if you see a question in the Q&A box that you like a lot, you can give it a thumbs up, and it will then move to the top of the list, and that will make it more likely that your question will be asked to the presenters. There will be not much time for discussion afterwards, but we will share all the questions in the Q&A box with the presenters afterwards, so you can continue the discussion after this webinar ended. So enjoy, and I now give over to our chair, Sven.
Yeah, welcome also from me. So this session features 3 selected papers from the original theme of health, well-being and morbidity. As Gusta already said, this was originally being organized by Kieran Barclay. So he did all the hard work, but couldn't be here because he is still in some cabin in Wisconsin, far away in the middle of the night right now. So yeah, without further ado, we continue and we start with Astrid, who will talk about does one have to be healthy to opt to have children in Norway. Please, Astrid.
Thank you so much. Can you all hear me? Yeah. I'm very happy to present this work, which is joint work with Lars Dommermuth and Ranveig Hart. This study is part of a larger project that was jointly financed by multiple ministries in Norway to look at different aspects that may or could help explain the decline in fertility that we have seen since 2010. So other aspects that were sort of looked at were religious affiliations, how many kids people want, welfare reforms and those things. But we got not stuck with, but we opted to look at health as one possible way. The full report has been published and all the different parts of the studies, and what I'm presenting here today is available as a working paper at Statistics Norway, so there's a link in this presentation if anybody wants more background information. So poor health may constrain women's capacity for active leisure, including family life and child rearing. It may impact on labor market participation and potentially affect preferences. It may, however, also make it challenging to conceive and carry a pregnancy to term. And what we know now is that treatment, follow-up care, and the prognosis for many medical conditions and disabilities are steadily improving. And more women reach fertile ages in suboptimal health today compared to the situation decades ago. We also know that older women have more pregnancy-related health problems than younger women, and with a steadily rising birth age, pregnancy and birth-related health problems can be expected to sort of continue to increase in the years to come. Norway has a strong welfare state which promotes health and gender equality. So persons are entitled to health-related benefits if poor health limits their ability to participate fully in the labor market. In this study, we look at benefits, so the uptake of benefits as a proxy for health. First, you usually use sickness absence, which is doctor certified. It can be given up to a year, and it's usually a full compensation of your wage. And if you haven't been employed or in the labor market, it's some sort of hard equation to figure out what you should get, but you can also get it then. Whereas the long-term benefits, we've sort of merged a lot of different types of benefits. They're usually only used after the year of sickness benefits, since the compensation rate is lower. There's also, and also young people can get this. The most prominent sort of long-term benefit is disability pension. Yeah. And over the years, the uptake of sickness absence has declined slightly, whereas the uptake of long-term benefits has increased, but slowly. Here you sort of see the women that are in our study, what their uptake rates are. I'm sorry. And you see that the yellow lines are sickness absence uptake, whereas the red lines are long-term benefits. So it's about plus minus 10% for long-term benefits and plus minus 20% for sickness absence uptake. And in Norway, there has been an increased focus directed towards the importance of work attachment, both at an individual and at a societal level. And strong incentive structures have been established to ensure that people sort of use the residual work capacity, and we're attempting to have people avoid the reliance on long-term benefits. So our research question here is, does health measured by the uptake of sickness absence or health-related long-term benefits influence the chances for having a child? We only use women here, and we use women who are born in Norway. So immigrant women are not included. That's mostly because the uptake of health benefits that we look at sort of are easier to measure when people have stayed in Norway for a year and have some work history. So we just wanted to have a clean data set. It's possible to include also immigrant women, but we haven't done it here. And our proxies for health are kind of conservative. The sickness absence indicator excludes short-term, less than 16 days of sickness absence. And we've also taken away all the sickness absence that are sort of surrounding pregnancies or births. The long-term benefits are hard to get. They require a substantial amount of documentation and government approval. So we think that we have fairly conservative health proxies that are sort of likely to capture actual health problems, although there's always people on the margins that some people who are in a certain state of health will choose to work, whereas others will sort of not choose to, but opt to use benefits. Yeah. We use a very standard approach. It's an observational study. We analyze first, second, and third births separately. And we have varying covariates in the different models. For the first births, we have not included partnership status, but we have looked at it for the second and third births, as one of the hypotheses was that some studies show that it's harder to find a partner if you're in poor health. Yeah, depending sort of on the reason for why you're in poor health, but that's sort of one issue that we'll return to. And our main results are that long-term health benefit uptake is negatively associated with fertility. So if you use long-term health benefits, you're less likely to have a child. We found the opposite for sickness absence uptake. Actually, if you have a lot of sickness absence, your chances of having a baby are higher. And we found fairly significant effects for both sickness absence and long-term health benefits for all parity transitions. The association was particularly strong for first births and weaker for second and thirds. But as I've put in the overall odds ratios here, so it's like a 30% increase for first births for sickness absence, 20% for second birth, and 10% for third births. Whereas the reduced chance compared to healthy women, defined as those not having sickness absence or long-term benefits, it was about halved for first births and 60 or 40% less for second births and 30% less for third births. This graph just sort of shows what I've seen, but it also shows the changes over time. The green line are the healthy women. Their chances of having, or it's the average predicted margins for having, for the healthy women for having a first, second, and third birth. The yellow lines are the sickness absence women, and the red lines are the long-term benefits. So you sort of see that the pattern is fairly stable across the parodies, although the axes vary a bit. Yeah. What we do know is that long-term benefits are likely to indicate a worse health than sickness absence, and it's normally only granted if health is really poor and unlikely to improve. The uptake is, however, only around 10%, and it hasn't really sort of, even if it has increased, it's not likely to explain much of the observed decline we've seen in fertility over time. The use of sickness absence, which is positively associated with fertility, is decreasing over time in line with sort of the incentive structures that the government has set up. And if this sort of decrease indicates that women are more likely and are more eager to join the labor market and prefer careers over motherhood, perhaps it might help explain part of the observed decline, but this we don't know. It's just an observational study. And then there are pros and reasons why you could think that poor health could increase sort of your fertility, and there are reasons why you could think that it might decrease. So some studies have shown that suboptimal health, and especially poor health, might increase persons' family orientations, and they might be more sort of geared towards having a family. And it might also reduce the ability to invest heavily in education and careers, thus making it sort of having a large family a comparable, more attractive option. We couldn't test this hypothesis directly. So it would be nice to also include men, and ideally also sort of compare health between men and women in couples. And if we find that poor health impacts equally on childless men and women, although women are sort of the ones who are burdened by the pregnancies and the nursing periods, it might indicate that women value parenthood more strongly, but we haven't done this yet. On the other hand, it might be expected to reduce fertility, as people might be afraid that they're not able to be healthy and caring parents economically and otherwise. And what we saw when we compared the sickness absence and the long-term benefits is that it's primarily the healthiest of the women in suboptimal health who choose to have children. So it looks to us that women take health into consideration when they sort of opt for parenthood if it is a choice. Yeah. And it's particularly strong for firstborns, and it doesn't sort of really matter if there isn't a large difference between the second and third child, but women with poor health who become mothers are more likely to raise single children. So it might imply that they sort of adapt to their health and their sort of ability to be good and caring parents, maybe. To conclude, our study contributes knowledge and association between health and fertility in an unselected cohort of women in childbearing age. We think when we looked at all the studies, there's quite a bit on studies on how sort of fertility affects your health, but there isn't so much focus on how health might impact fertility. Also, a lot of the work that is done on very sort of specific diagnostic groups. A major weakness of our study is that we do not have diagnostic data on the various benefits that are used. That information is possible to get, but we don't have it here. Yeah, and as we stated in our report and in the working paper, we cannot conclude that the observed decline in fertility in Norway is due to women being in poor health today. Because what we actually did see is that the decline in fertility was strongest for the healthy women over time. So thank you so much.
Thank you very much, Astrid, sorry. I would like, so we will now immediately continue with Iñaki. Just a reminder to everybody, if you have questions to Astrid or any of the other presenters, please post them in the Q&A and feel free to upvote those questions as you want. Now we'll continue with Iñaki, who will talk about healthy lifespan inequality across Europe.
Okay, can you see the screen?
Yes.
Okay, great. So I'd like to start thanking the organizers for having selected this paper for being presented here today. Thanks also to Kieran and thanks to Sven as well. So this is a measurement paper. It's a paper about proposing new measures of population health, something that I called healthy lifespan inequality. So I'll try to spend, let's say, half of the presentation trying to convince you that there's a need for this new class of population health measures. And the other half of the presentation, I'll try to get like the first estimates of these new indicators and try to understand what they mean and so on. So let me start with a revision of what I call measures of population health. Here, basically, I think about indicators that are telling us on, what's the population health status in a given country, in a given year. So the most perhaps widely used and best well-known indicator, it's life expectancy. That's telling us on average how many years individuals are expected to live under current mortality conditions. But as you know, well, life expectancy, it's very useful, but it has also its limitations, right? One of the issues for which it has been criticized is that it's just a measure of measuring how many years are you expected to live, but it's telling nothing about the health quality of those years, right? So that's the reason why a new class of measures appeared called something like health expectancy indicators, where basically they're telling us on average how many years are you expected to live in good health, right? And there's a whole bunch of indicators measuring this, like disability-free life expectancy or disease-free life expectancy and all sorts of whatever-free life expectancies. Okay, that's a line of indicators that's introducing the notion of quality, not just quantity of years, but also the quality in terms of health. That's another family of indicators that exist. Another of the criticisms that life expectancy has received is it's just an average. It's telling nothing us about the variability, right? It's not telling us whether some individuals are living much longer than others. And that's the reason why in recent years we have observed like the appearance of this other broad class of measures called lifespan inequality indicators. That's, again, it's telling us how much unequal these age-at-death distributions are. And in this vertical axis, I have highlighted that we're moving from efficiency-like indicators, like a mean indicator like life expectancy, towards an equality-oriented one. So basically, my point in this presentation is to tell you that, well, if you look at this diagram, there's like a missing piece. There's a gap. It's natural to feel. And look, we're looking at in this slot how many years are expected to live in good health. Sorry, how many years are expecting to live? In this one, how many years are expected to live in good health? And in this one, we're measuring how unequal these lifespans are. So there's just this gap that should be filled, something which I called healthy lifespan inequality, which is a new class of measures that so far has not been introduced, as far as I know, which is measuring to what extent healthy lifespans are equally or unequally distributed, right? And the interesting feature of this class of indicators is that it's taking into account both axes simultaneously. These quantity-quality axes, we're taking into account the quality of health, but also the extent of inequality, right? Something which did not happen with the previous lifespan inequality or health expectancy indicators. Just to try to illustrate how this can be useful, I'm showing you now like a couple of hypothetical artificial examples where traditional health expectancy and lifespan inequality indicators fail to give like a good diagnosis of what's going on. In this artificial example, for example, we have age and morbidity onset distributions. We have population A, where all individuals start developing, let's say, a chronic disease around the age of 60, and a population B, where half of the population develops that chronic illness, let's say, around 40, and the other half around 80. And traditional health expectancy indicators would conclude that these two populations are the same, because the average is about 60, and we are not making this distinction, right? That in some populations, morbidity starts at earlier ages than others. That's an example where health expectancy might fail to be sensitive. And the other artificial example is this one, where we have like a mortality and a morbidity curve in this fictitious population. Everyone is dying at the same age, at the age of omega, more or less, but half of the population spends half of their lifetime in bad health conditions, and the other half spends the entire lifespan in very good health conditions, right? So traditional lifespan inequality indicators would conclude that there's no health inequality because everyone is dying at the same age, omega, but it's not taking into account the fact that a great sector of the population is starting developing like a chronic disease or whatever much earlier on, right? And again, this is another example where healthy lifespan inequality indicators would be very useful. Okay, so there are also substantive reasons why I think these new healthy lifespan inequality indicators are important. Well, basically, these new indicators would be able to uncover some heterogeneity in the distribution of good or bad health, less than perfect health, something that currently does not exist. So, among other things, could be useful to explore, inequalities within and between socioeconomic groups that have not been explored so far. I think that this could help to enrich our understanding of contemporary health dynamics. Among other things, it could help to throw some light into these long-standing compression versus expansion of morbidity debates. And it could help to understand the drivers of health heterogeneity, right? Not just in the population as a whole, but insist in, within groups, socioeconomic groups, and across them. And finally, of course, I think these fine-tuned indicators could be useful to orient, fine-tune evidence-based policies. I know if I succeeded in convincing you about the interest of these new healthy lifespan inequality indicators. But anyway, the second half of this presentation, I'm going to try to show you like an empirical application, try to see how these indicators behave for a bunch of European countries, and compare them with respect to existing classical population health indicators. So I'm start just briefly trying to show you how I'm planning to estimate these new healthy lifespan inequality indicators together with the traditional indicators of population health. Basically, I'm trying to mimic somehow like the Sullivan approach, where we have mortality and morbidity curves, this survivor curve L of X, and the morbidity curve, which I call L prime of X, which basically I obtain by multiplying the survival curve, this L of X, by 1 minus pi of X, right? Where this is the proportion of the population at that age that are in good health. Well, these are well-known curves. From these curves, if you look at the area below these curves, you obtain the traditional life expectancy indicators and health expectancy indicators. The fact that the morbidity curve is below the mortality curve, of course, gives us lower values of health expectancy than life expectancy. So this is as regards the estimation of these population health, average population health indicators. But as I said, I'm more interested not in the average of these indicators, but in the variability in the distribution, okay? So from these survival curves, I derive this number of deaths, dx, and d prime of x. So basically it's the same idea. I'm subtracting L of x from Lx plus 1, sorry. And this gives you the number of deaths. Or for the case of d prime of x, the number of individuals ceasing to be in good health between ages x and x plus 1. And we get this number of death or number of individuals ceasing to be in good health between different ages, these typical distributions. from which I'd like to measure how dispersed, how unequal they are, right? From these two distributions, basically I'm applying a measure of inequality. For this example, I have used the Gini index, but could be whatever, right? These indices are defined between 0 and 1 and give you the extent of inequality. Regarding data, I'm using mortality data from the human mortality database. And as regards morbidity data, I'm using data from the EU SILC. In particular, I'm using the GALI indicator, where basically respondents are asked if they, for the past 6 months or more, been limited in carrying out usual activities due to health problems. Okay, this is for the morbidity part. And because of small sample size, we have to restrict our attention to the age range between 15 and 79. This is the bunch of 12 countries we picked for our analysis. The reason for not choosing more is that these 12 countries have very similar questionnaires for the GALI question. Other countries have similar but not exactly equal ways of wording the GALI indicator. So that's why we stick to these 12 countries. Now let's go to the results. Basically, I'm showing 4 scatter plots. In these 4 scatter plots, I'm showing the 12 countries I mentioned before in 2 points in time. I forgot to mention that we're taking observations, between around year 2005 and then 10 years later, 2015. So basically in these different scatter plots, the countries are observed twice, around 2005, 2015. In the first column, we have results for women. In the second column for men. In the first row, we are comparing life expectancy versus lifespan inequality. And the second row, we're comparing health expectancy versus healthy lifespan inequality, the new indicators. So what can we say from these figures? There's a lot of things we can say, and just going to summarize some of the things here that you can see, but it's not exhaustive. I'm starting saying that differences in health expectancy across countries are larger than differences in life expectancy. There's more variability across countries in terms of health expectancy. I also wanted to mention that the female advantage in life expectancy disappears when we're looking at health expectancy indicators, which is something we already knew. We also know that socioeconomically advantaged countries tend to exhibit lower levels of lifespan inequality and typically higher levels of life expectancy as well. And lifespan inequality, typically it's higher among men. Okay, so far, I mean, these results are well known. This confirms what we already suspected. What's new here is when we observe the new healthy lifespan inequality indicators, which basically, if you look at the graphs, we can see that healthy lifespan inequality is substantially larger than traditional lifespan inequality. For men, on average, these indicators of HLI are 55% higher than life expectancy indicator, the lifespan inequality. And for women, it's 85% higher. So basically the takeaway message is that healthy lifespan inequality, it's much more, it's higher than traditional lifespan inequality. So age and morbidity onset distributions are more unequally distributed than age-at-death distributions, right? Other issues that we observe in the graph is that the levels of healthy lifespan inequality tend to be slightly higher for women, not much, but slightly higher. And as regards changes over time, there's kind of an erratic pattern as regards health expectancy and healthy lifespan inequality indicators. So just to conclude, I think that this new set of indicators can uncover new layers of health inequality that cannot be traced with currently existing methods, basically with life expectancy, health expectancy, and lifespan inequality. So it's a complement to these measures. But of course, I mean, there are some limitations in this paper, because basically following this Sullivan approach, which is known to have several limitations and something that can be improved in the near future. And also there's the issue that they chose the GALI indicator, which of course in future work it should be changed and look at for consistency with other population health measures. And just let me conclude telling you that these are some advertising. These are the preliminary results of an ERC consolidator grant that I recently received, investigating these issues of healthy lifespan inequality. So if you're interested in this, please do not hesitate to get in touch with me. And thank you very much.
Thank you very much, Iñaki. Again, if you have any questions to Iñaki, please add them to the Q&A box. We will now move on to our third speaker, Jennifer Dowd from the University of Oxford, who will talk about the effect of a targeted cash transfer on cognitive function in later life.
Great. Can you guys hear me?
Yes.
All right. Perfect. Thanks very much, EAPS, for organizing this session. It's really nice to interact with people despite not being there in person. This work is joint with Dr. Emily Courtine, sorry, my phone, and Sally Hayward, who are both now at the London School of Hygiene and Tropical Medicine. And this work is part of the beginning of a larger project where we're hoping to look at cohort changes in cognition, as well as risk of Alzheimer's and dementia that have changed over time. And we're particularly interested in how social policies might have impacted these changes across cohorts that we've seen in both cognitive ability and dementia. And sorry, I'm just trying to see my notes here. We kind of start from this idea of cognitive reserve. We know that cognition and declines with age, unfortunately for all of us. But there is evidence that certain interventions, especially earlier in life, might be able to kind of boost the level of reserve that makes people more resilient to these declines and sort of postpones that threshold at which functioning is lost and things like dementia kick in. And so our broader question is how social policies or other social environmental impacts might be able to increase this cognitive reserve and delay age-related cognitive decline. And so just as some background, we're going to look at an income support policy with regards to cognition at older ages. And there is some pre-existing work looking at relationships between higher income and better cognition. Not very much of this has been sort of quasi-experimental, but there were a couple papers, one using the Social Security notch in the US that did find sort of this exogenous increase in Social Security income, improved cognition to a clinically relevant level. And more importantly, there are some mechanisms that we believe make this plausible, that higher income may reduce financial strain and stress, lead to fewer depressive symptoms. It might also improve your health behaviors, which could improve cognition. There's biological evidence about the role of chronic stress and depression affecting certain areas of the brain that affect memory, as well as executive functioning. There's also, potentially effects in the other direction, whereby higher income might induce earlier retirement that could reduce cognitive function. And it's unclear whether sort of policy-induced changes in income can actually improve cognition. So that's what we want to look at. And we use a winter fuel payment cash transfer in the UK as a quasi-experiment to try to get at the potential impact of income support and individual income on later life cognition. But we have sort of this extra dimension. It wasn't yet to complicate it a little bit further. We were interested also in interactions between the social environment and genetic susceptibility for Alzheimer's. And this literature on gene by environment interactions has sort of a few different hypotheses of how the social environment might interact with genetic risk. The first is kind of the social trigger idea, the idea that especially if you have sort of a risky genotype that might give you elevated risk for Alzheimer's or dementia, for example, it really might not get triggered or express itself unless there's an adverse type of social environment that triggers that susceptibility. So if you have a good education and a good neighborhood and living situation, that gene might not be expressed, but if it's triggered by a bad environment, you might see that elevated risk. And there's another idea that's called social push that suggests that negative environments might overwhelm, the effects of genetic variation. And I think about this sort of with the genetics of height, that, in historical periods and in countries where malnutrition is very high, you know, a lot of people were short because of the poor nutrition and environmental conditions, whereas today and in countries with, you know, abundant food, those genetic differences in height are kind of allowed to shine through. So that's the social push idea. And there's also a theory about differential susceptibility, that individuals with certain genotypes might be just more reactive and sensitive to the social environment, whether that's a positive or negative effect. And this is sometimes referred to as the orchid versus dandelion hypothesis. And so one challenge of kind of looking at gene by environment interactions with social exposures, as you all know, is the potential that you know, genes and environments are correlated. So in this sense, the environment is endogenous to your genes. It's partly selected by your family, for example, which, you know, is correlated with your genes. And some of the early examples of gene by environment interactions, such as childhood maltreatment, you know, you obviously get both your child maltreatment and your genes from your parents. So in a sense, this is not, you know, the cleanest way to think about gene by environment interactions. And things like your neighborhood environment or even the stress that you experience are also probably a function over your life course of different ways in which you selected your environment. So to overcome this challenge, it's been proposed that we should try to kind of leverage exogenous variation in the social environment in conjunction with gene by environment interaction studies. And, you know, you can imagine this is a challenge to find data where it's both large enough to kind of use quasi-experimental designs and have genotype samples. So there aren't too many examples of this thus far. But Fletcher and colleagues in the US found that individuals who were less genetically susceptible, you know, responsive to nicotine, so less likely to be addicted, responded more strongly to state-level tobacco taxation policies. So they were kind of more able to respond to price increases and give up smoking. And a more recent paper with the UK Biobank found that additional education that was induced by compulsory schooling laws was associated with greater reductions in BMI for those who were most genetically susceptible to obesity. So kind of consistent with that social trigger idea. And to our knowledge, ours is the first to try to look at a quasi-experimental social exposure and genetic susceptibility for cognitive function. So a little bit about the policy that we're looking at. The winter fuel payment policy in the UK was introduced in 1997 to help older people meet the cost of heating their homes. It's about £250 for individuals ages 60 to 80. And, you know, it comes once a year, so that sounds like a small amount, but it is equal, about equal to rough median weekly income for this age group. And it's paid just based on having one individual age 60 or over in the qualifying household at the time of eligibility. So the important part there is that it's not means tested. It's really just once you pass that age cutoff, you are eligible for the winter fuel payment. And so you can see that big discontinuity of receipt at age 60 in the ELSA sample that we're using. And that there is very high take up of this because you're sort of automatically enrolled in it if you're in the system for other reasons. So most people do receive the payment. We're using data from ELSA, the English Longitudinal Study of Aging, individuals age 50 and over, and data from 2002 to 2010, which covered the variables that we needed. And our primary exposure is they actually ask people if they receive the winter fuel payment, and most who are eligible do indeed receive it. We can also just use eligibility and get similar results. And our outcomes are cognitive function assessed with some standard tests that cover 3 different domains: memory, processing speed, and executive function, but also a global cognitive function score. And to test for these gene by environment interactions, we're using polygenic scores available in ELSA for a subset of participants. And if you're not familiar with these scores, they're kind of weighted averages of lots of small SNPs that predict an outcome like Alzheimer's or overall cognition. So they're picking up a lot more small effects and combining them into one score. And we use these polygenic scores for both general cognition, which is a little bit more like IQ, and also risk of Alzheimer's disease. And then we run separate models for those, and also interacting the receipt of the winter fuel payment with these polygenic scores. And I'll just go quickly, but we use individual fixed effects models. So we're following the same people over time. So we're actually using the change in their individual cognition upon receipt, kind of switching from not receiving the winter fuel payment to receiving it. And the idea is that the individual fixed effects will help adjust for measured and unmeasured time invariant confounders. And but we do adjust for some potential time varying confounders, such as disability activity limitations and changes in employment status, etc. And so ultimately we have about 3,500 individuals who switch from not receiving the fuel payment to receiving it over the time period. And we're essentially looking at their change in cognitive score upon receipt of the payment. And finally, we interact that receipt of the payment with the polygenic risk score for Alzheimer's and cognitive function. So sorry for going through this quickly. But our results, we do find a main effect of receipt of the winter fuel payment on global cognition, a positive and significant effect. And this seemed to be concentrated or stronger for executive function when we broke it up by a specific domain. So receiving the payment was associated with 0.03 standard deviation increase in the executive function score. So that's just the main effect of receipt without the G by E interaction. We see here that when we do the interaction, that the beneficial effect of receipt of the payment on global cognitive function was greatest for those who had the highest genetic risk for Alzheimer's. So those in the top quartile of the polygenic score for Alzheimer's risk, it was associated with 0.08 standard deviation for cognitive function. And we did not see any interaction, as you can see, for the polygenic score for general cognition, which we thought was interesting. So just to summarize, this winter fuel payment cash transfer was associated with better overall cognition. And this was a very small policy. So in some ways we were surprised to see any effect. So it is a small effect, but it's also a small policy that might be suggestive, that small sums of money have the potential to help, improve outcomes in older populations. And the stronger effect of the winter fuel payment on cognition in individuals at the highest risk for Alzheimer's disease, suggests that in general, social policies might be able to reduce, gaps in cognitive function amongst those with different, varying genetic risks. It kind of helps reduce that variability. And so I know that was really quick, and I look forward to so thank you very much.
Thank you very much, Jennifer. If you have questions to Jennifer, please add them to the Q&A. We will now have our discussion, and we will start with some question for Astrid. I try to give the name for everybody who had a question, but please excuse any terrible pronunciation. So we had one question from Eva Bourgeois. That was the first example, probably, of the bad pronunciation, who asked, given that health certainly depends on age, fertility postponement may have affected the relationship between health and fertility over time. Did you test that, Astrid?
It's a very good idea and a very good question, and I most definitely will do. We're still we're trying to get this working paper into a real paper, so thank you. What we have done is just control for age, so we haven't tested it.
Okay, we also had a question from Jerome Spiker. Could there be an issue of endogeneity? Women are more likely to get sick during their pregnancy. So did you check when these women were on sick leave?
Yes, we tried to take care of that. Since we didn't have the diagnostic information, we couldn't tell if sickness absence or long-term benefits were directly related to pregnancies. So all the sickness absence and health related benefits have been lagged so that they are 1 year prior to conception. We also tried to aggregate. There was another question about whether or not it matters if you're sick the year or two before. So we did check if you had been sick up to 5 years before the year before you get pregnant, or up to 3 years before the year you get pregnant, and that didn't change the results at all. So it's mostly the same sort of women who tend to use sickness absences. Yeah.
And maybe one more from Bruno Pino, who asked whether you know the type of health limitation that might matter. So would it be possible to test that with this register data?
That would, it is possible, and it's a weakness of this study. We would need to link medical information to this registered data, so it would sort of fall into a medical sort of regulation framework. So it would require a lot of sort of permissions and stuff, but it is possible, but it would be a different study because it would have to require all new linkages. Yeah.
I had a personal other question, because sickness absence or sickness does not only reflect like health, it also reflects economic constraints. So how do you, because the replacement level of this is generally not the same, how do you, can you distinguish between health and the economic constraints that affect fertility?
We have looked at both the use of the health benefits depending on your income levels, and it didn't really matter whether or not you had a high or a low income. We do have the sums that people get. We didn't go into that. There was also another question where if we could look at the amount of time, and we also have the number of days, so we could do more refined analysis on that. But for now, we haven't. What we know is that for first births, there's quite a lot of students in the, not for first, yeah, in the women eligible to have a first child, there's quite a few students, and they usually have very low income. So we've done analysis where we've taken out the students. It didn't change the results either. So we kept them in the end, but in the working paper, we show the results with and without students. Yeah.
Okay, thank you. There were also a few questions for Iñaki, one long one from Tim Riffe. So regarding your take-home message that this new indicator is having a higher, showing a higher inequality than the traditional measures, could this be more the case for reversible states than for irreversible states? So because for some activity limitations, that can change over your life course.
Yeah, thank you very much, Tim. Very good question. I think, yeah, your intuition must be right. I guess the less strict you are with your population health measure, the more inequality you will observe. If you're taking like a not very strong indicator like the GALI, meaning, as you said, that you can go back and forth, you can recover from an illness and so on and so forth. It's, of course, it's to be expected that occurrences might happen earlier in your life. So meaning that the inequality of the distribution will be higher. So I guess if, well, these are, of course, the initial, the preliminary analysis of this project. And I guess in the near future, when we are able to incorporate like kind of a gradation, if you want, of population health, of health measures, becoming more and more strict, if you want, I guess the levels of inequality that you observe gradually shift from higher levels to lower ones as you incorporate more and more strict conditions of what it means to be in good health. You have like an irreversible condition. I would expect these values to be slightly higher than lifespan equality, but not that much as we're observing with the GALI index. Very good point. Thank you.
And another question from Alessandra Carioli. How do you think life quality indicators can give insights to instances of high inequality within populations? and she's thinking of the 2014-15 decrease in life expectancy for the UK, for example.
Well, thank you, Alessandra. I think you're highlighting a very important point. I mean, the issue of quality of life. I'm pretty sure that these inequalities you're referring to in the UK and everywhere else, I guess, must be pretty much related to the socioeconomic conditions of these populations. And this is one of the reasons why in this project we wanted to focus on what's happening across and within socioeconomic groups. And I'm pretty sure that quality of life must be one of the drivers of these inequalities in health. And that's the reason why I want to focus in there, not just for the case of the UK, but everywhere. We had also some preliminary analysis for the case of Spain, looking at differences across education groups. And we are observing like these different behaviors across these groups, which is more or less related to the issue that you raised. Thank you.
And maybe one more here. Could your measure be used for the current pandemic?
Yes, of course. I mean, good. I mean, of course.
Did you try?
Sorry?
Did you try?
I mean, yeah, we could try that. I mean, of course, when I wrote the proposal, the pandemic was not there, but of course we must adapt to the circumstances, and I guess it can be done, and I'm pretty sure it should affect not just these healthy lifespan inequality indicators, but all of them. It will affect, to begin with life expectancy, but also healthy life expectancy and all sorts of indicators, and in particular the new one. So it's like here, yeah, it's a good opportunity to investigate how these shocks affect, you know, these population health indicators. Yeah.
Thank you, Iñaki. We also had a few questions to Jennifer. Mutitsu had a question. What do you think about the estimated size of the coefficient? They look a little bit small. Is this common?
They were quite small, and it's hard, and so sorry, because we didn't have time to go through too carefully. These were Z scores for standard deviation. So you're right, sort of 0.02 standard deviations is quite small. We tried to calibrate it with some other interventions on cognition. The Social Security notch paper was a much larger cash transfer. But even so, I think that improved cognitive scores by 2 or 3% for, you know, probably $1,000 or $2,000 a year, an income bump. And then there was just one other paper that had a new bus pass for elderly people in the UK, and kind of looked at the experiment of how that changed cognition over time. And our kind of effect sizes were qualitatively similar to that. And I think in some ways I was surprised to find any effect. So the small effect didn't surprise me. And again, in some ways, this was kind of a proof of concept, trying to see if you could do gene by environment interactions with social policies. So I agree. I think it might suggest that larger, you know, policies and I think also sort of layered sort of supports for older people and social support in general, you know, might have bigger impacts. But it's absolutely true that this was, you know, both a small exposure and a small effect, but it was surprisingly actually detectable in the data.
And one more question from Bruno Apino, and maybe you mentioned it, but did you restrict the analysis only to eligible individuals? And did you examine heterogeneity in the effects, for example, by income or other socioeconomic?
Oh, yes. I mean, almost take-up was extremely high, like over 90%. So we looked at both people who reported receipt and also in sensitivity, just people who were eligible, and the results were pretty much the same. And yes, we actually have tried to look at heterogeneity because it would make more sense if this, you know, was a stronger effect for people with lower income and lower wealth. And we did not find significant interactions with stratified by income and wealth. And that honestly is one concern we have, that kind of doesn't make sense in principle. So it's something that we're still writing the paper and kind of continuing to explore some other sensitivity analysis and sort of some other placebo effects. Because we want to make sure that we're not picking up something else that might be going on despite our best efforts. So that's an excellent point.
Thank you, all the speakers. I think we covered almost all questions. There was one more for Astrid, I think, who was asked whether the inclusion of immigrants would have potentially changed your results.
Yes, and I discussed it with my co-author here just now. We didn't include immigrants because we were unsure about how well we could sort of find them in the health registers. We don't really know how their uptake of health benefits is compared to the general population, and we should know that. In general, I believe it would depend on the type of immigrants. Like labor immigrants, I guess, would be less likely to be unhealthy and perhaps also return to their countries if they do become unhealthy. So we wouldn't sort of capture the births in Norway. For immigrants and family migrants, we know that fertility declines fairly rapidly with duration of stay in Norway. So their fertility is high when they come, and when they come, they haven't sort of earned a right to have a health benefit. So it's something we should think about in the future going forward, but I think we would need different proxies for health to answer that question fully. Thank you.
Okay, I think it was, despite this new format, was very interesting, the discussion, or at least the question and answers. So thank you very much. Thank all the speakers and all those who asked questions and who upvoted questions. Otherwise, I was told that I should wrap it up. So I will wrap it up. Thank you for everybody. And Gusta, you will take over from now.
Yes, thank you. Well, also thanks from our side to all presenters and to you, Sven, and of course for all of you who joined this interesting session. I would like to remind all of you that this was the 6th webinar in our series of webinars. So you can tune into the next one, which starts at, let me check, 12 o'clock Central European Time, about fertility in times of crisis. I think also related to the COVID crisis, so that might be interesting to join. And then after that, at 2 o'clock, you can also attend a session about internal migration and segregation of migrants. So you're all more than welcome to participate. And there's a final thing I would like to say, and that is that after these EPC webinars are finished, we will continue with EAPS webinars. So webinars are becoming increasingly important to share your research with scholars around the globe. And hopefully Corona will not stay, but these webinars will definitely will. But you will receive further information about that when we know how that will work and what it will look like. So thanks again to everybody, and hopefully see you at 12.
And I would clap for the presenters.